Assalamu alaikum wa rahmatullahi wa barakatuh. Welcome to the channel of Stand Medical Notes. So, from now onwards, we will move on to a new topic, that is discussing the cardinal manifestations of endocrine diseases. The cardinal manifestations of endocrine diseases. So, let's begin with the name of Almighty. We will discuss gland by gland, their required anatomy, physiology, and the medicine part. Okay. So first of all, we should know what are the presenting problems in endocrine diseases. Endocrine diseases present in many different ways and to clinicians in many different disciplines. Classical syndromes are described in relation to individual glands in the following sections. Often, however, the presentation is with non-specific symptoms. The presentation is with non-specific symptoms, which is given in box 18.3, or the presentation is with asymptomatic biochemical abnormalities. So this is first one, this is second one. Okay. In addition, endocrine diseases are encountered in the differential diagnosis of common complaints including electrolyte abnormalities, hypertension, obesity, and osteoporosis. So this is the third type of presentation. So we have three types of presentation in endocrine disease. One is patient presents with non-specific symptoms like cold intolerance, hot intolerance, weight gain, weight loss, excessive fatigue. Okay, all these are polydipsia, polyuria, all these are non-specific presentations. Or the patient may not have symptom and he have asymptomatic biochemical abnormalities. That is number second. Number third is the patient present with electrolyte abnormalities, obesity, osteoporosis, hypertension. Electrolyte abnormalities, hypertension, obesity, and osteoporosis. These three types of presentations we will get in any type of endocrine disease. Number one is a what do you call non-specific symptoms. Number two, asymptomatic biochemical abnormalities. Number three, electrolyte abnormalities while evaluating electrolyte abnormalities, hypertension, obesity, and osteoporosis. Although diseases of the adrenal glands, hypothalamus, and pituitary are relatively rare, their diagnosis often relies on astute clinical observation in patient with non-specific complaints. So it is important clinicians are familiar with their key features. So diseases of these adrenal glands, hypothalamus, pituitary are rare, but we should suspect. Okay, depending upon the presentation. So these are the three types of presentations a patient with endocrine disease comes. So let us see what are the non-specific presentations of endocrine disease. So number one is lethargy and depression. So just to remember the endocrine diseases, you just remember this diagram. Okay, this diagram. Okay, with this we'll know what and all abnormalities we can see. So because this is hypothalamus, this is the brain, this is hypothalamus. So so we should remember hypothalamus in our mind. Then diseases of anterior pituitary, for example, like anterior posterior pituitary due to a tumor or due to Sheehan syndrome, for example, I'm saying. So it will lead to acromegaly. Okay, for example, central hypothyroidism or central hypogonadism, all these things. So disease of the pituitary will lead to some endocrine disorder. So this is thyroid, so it can lead to hypo or hyperthyroidism. Okay, so behind the thyroid you have the parathyroid gland. So hyperparathyroidism is a common thing which we will see in the practice. Hyperparathyroidism. So this is pancreas, so you will have the beta cells of pancreas here. So you can see you will see diabetes mellitus. Okay, either it can be type 1 or type 2. Along with that, you can have diabetes insipidus also. So it is related to actually brain, pituitary. Okay, and this is the kidney. Above the kidney you have the adrenal gland. So you can have what do you call so adrenal gland have cortex and medulla. So cortical is this one. So Cushing syndrome you can have, Cushing syndrome, or you can have Cone syndrome, Cone syndrome, and you can have uh, Cone syndrome or Cushing syndrome, just or adrenal crisis, primary or secondary adrenal insufficiency, what do you call? Okay. Now these are gonads. So it can be hypogonadism or hypergonadism, hypogonadism, gonadism, or hypergonadism. Okay. Okay. Then one more thing is you will have breast in the females. No, here. So here you can have hyperprolactinemia, prolactinemia. You can remember. So what I want to say by drawing this diagram is we can remember the glands and we can think we have a memory about these endocrine glands, so that we uh, it gives a very good um, approach. Okay, we will have the diseases in the mind, endocrine diseases in the mind by this diagram if we imagine this diagram in our mind. Okay, so that's why I said if you remember this anatomy, then according to that we can remember the pathology of the endocrine diseases. So number one is lethargy and depression. So it can be hypothyroidism, diabetes mellitus. These two are very much common diseases, remember this point. And hyperparathyroidism. Okay, this is also common sometimes. Adrenal insufficiency, in that secondary adrenal insufficiency is common. Hypogonadism, Cushing syndrome. So see here, as I have discussed, so this is something related to thyroid gland, this is something related to pancreas, this is something related to parathyroid gland, this is something related to gonads. Okay, this is something related to adrenal gland, this is something related to adrenal gland. So any disease of thyroid or pancreas or adrenal gland or gonads can produce lethargy and depression. Second is weight gain. So thyroid gland or adrenal gland abnormality like hypothyroidism, Cushing syndrome can cause weight gain. Third is weight loss. So thyroid gland or adrenal gland or the pancreatic beta cells disorder can cause weight loss. For example, like thyrotoxicosis, adrenal insufficiency, and diabetes mellitus. Common is this thyrotoxicosis and diabetes mellitus. Polyuria and polydipsia, where you see again abnormalities of the pancreatic islet. Okay, and this is diabetes insipidus. So it is from the pituitary, and this is from the parathyroid gland, and this is from the adrenal gland. So polyuria and polydipsia we seen most common is diabetes mellitus. Second is diabetes insipidus. Then hyperparathyroidism, hypercalcemia, because hyperthyroidism causes hypercalcemia, that will lead to polyuria. And hypokalemia like Cone syndrome. So in Cone syndrome, there is excessive production of aldosterone. So that will lead to loss of preservation of sodium and loss of potassium and proton into urine. So that will produce polyuria. So any abnormality like diabetes mellitus, most common diabetes insipidus, hyperparathyroidism, and Cone syndrome can cause this polyuria. And fifth is heat tolerance. So this you see in, just remember thyroid gland abnormality, the thyrotoxicosis, and menopause, women who are having menopause, heat tolerance. Then sixth is palpitation, again thyrotoxicosis, and again this is a tumor of adrenal gland, that is cortical medulla, that is pheochromocytoma. So any abnormality of thyroid gland or the cortical medulla can cause palpitation. So that like that we can remember. For example, like thyrotoxicosis and pheochromocytoma. Number 7 is headache, where you see acromegaly, any pituitary tumor, and pheochromocytoma. Okay, so the disorders of the adrenal gland like growth hormone excessive production, or any tumor of the thyroid gland, or pheochromocytoma. So remember the triad of pheochromocytoma. What is the triad of pheochromocytoma? Number 1, headache. Paroxysmal attacks will be there. Paroxysmal episodes of headache, palpitations, and third is hypertension. So this is the triad of this pheochromocytoma. Okay, then this is also very important, muscle weakness. We don't proximal muscle weakness. For example, patient has a difficulty in raising the hands above his head, or difficulty in combing the hair. So this is proximal muscle difficulty of the upper limb. Similarly, patient has difficulty from standing from squatting position, or sitting up from the chair, so where these proximal muscles are required. So there you can suspect some endocrine disorder. So any thyroid gland disorder or adrenal gland disorder, or this adrenal gland disorder or parathyroid gland disorder or some gonadal disorder can produce this one. So thyroid gland like thyrotoxicosis, okay. Cushing syndrome also can cause proximal myopathy. Thyrotoxicosis can also cause proximal myopathy. Cushing syndrome can also cause myopathy. Cone syndrome, because there is hypokalemia in Cone syndrome, so that's why there is proximal myopathy. And hyperparathyroidism, so there is hypercalcemia actually here. In hyperparathyroidism there is hypercalcemia, so that is causing proximal myopathy. And hypogonadism, okay. And ninth is coarsening of features, you see in hypothyroidism commonly, and acromegaly. So most, if I give them order, so this was, we have discussed the features. So they present with lethargy and depression, weight gain, weight loss, polyuria, polydipsia, heat intolerance, palpitation, headache, muscle weakness, proximal, and coarsening of features. So these 9 types of non-specific presentation they can have. So commonest I will mention, number 1 I will mention thyroid, okay. So thyroid. Number 2 is diabetes mellitus. Number 3 you can take it as your adrenal gland disorder. Adrenal gland disorders, number 3 common. Number 4 you can take it as your so number 1 is thyroid, number 2 is diabetes mellitus, then adrenal gland disorder, then comes the parathyroid gland. So this is how you will have the common things. So these thyroid and diabetes mellitus are common. Second thing, adrenal gland. Then comes the other disorders. So that's about the non-specific presentations of the endocrine diseases. What are the non-specific presentations? Just to revise. So that is lethargy and depression. Number 1, lethargy and depression. Lethargy, depression, weight gain, weight loss, headache, palpitations, okay. Hypertension also you can think of, palpitation, proximal myopathy, coarsening of the features, okay, and polyuria, polydipsia. All these are non-specific features of your endocrine disorders, okay. Then second thing which is common in this is they present as asymptomatic biochemical abnormalities. Or third common thing is electrolyte abnormalities, hypertension, obesity, osteoporosis. So in these patients also you should suspect some adrenal disorders, okay. Now that was about the presenting problems in endocrine diseases. The 3 types of presentations are there. Now coming to the first gland, that is thyroid gland. So before going to the diseases itself, first we should know the required functional anatomy and physiology of the thyroid gland. So let us discuss about that. So functional anatomy and physiology. The adult thyroid gland weighs 12 to 20 grams, consists of 2 lobes connected by an isthmus located just below the cricoid cartilage, and is highly vascularized. The recurrent laryngeal nerves traverse the lateral borders, a critical anatomical relationship during thyroid surgery. So that's our the basic. So if this is the thyroid cartilage, okay. If this is the thyroid cartilage, this is the trachea. This is the cartilage. Here you will have the thyroid gland like this, okay, like this, the thyroid gland. So these are the 2 lobes, lobe 1, lobe 2, and this is known as the isthmus, okay. Now the next important thing to know is the hypothalamic-pituitary-thyroid axis, HPT axis, very important to know, okay. So otherwise we will not be understanding the investigation reports. So hypothalamus-pituitary-thyroid axis, how it functions. So this is the physiology. So from the hypothalamus there is synthesis of thyrotropin releasing hormone. Remember this TSH, the other name for TSH is thyrotropin or TSH, okay. That means TSH releasing hormone or thyrotropin releasing hormone is released from the paraventricular nucleus of hypothalamus, that will go and act upon the anterior pituitary cells. What are those pituitary cells? That is thyrotroph cells, okay. TRH will act on thyrotroph cells of pituitary, okay. Now these cells, thyrotroph cells, will produce the thyrotropin or TSH. So both names are synonymous. So TSH is produced in this, and it gets released into the circulation, and it will go and stimulate the follicular cells of the thyroid gland. Follicular cells of the thyroid gland. Okay. Now, this thyroid gland will produce, so it is not given here, I will draw like this, T4 and T3. Okay, T4 and T3, triiodothyronine and tetraiodothyronine. Okay, so there is a negative feedback mechanism actually. When there is increased T4 and T3, so they will go and they give signal to this hypothalamus and anterior pituitary that the hormone levels are increased in them. So that will cause decreased release of TSH from the anterior pituitary. Okay, so that means when there is hyperthyroidism, meaning when there is increased level of T4 and T3, you will have decreased TSH. So that's one basic point. Similarly, the opposite thing. What is that opposite thing? The opposite thing is when there is decreased level of T4, T3 for any reason. Okay, that is known as hypothyroidism, no, actually. So that is a state of hypothyroidism. So that will give a negative feedback mechanism to the hypothalamus and anterior pituitary, and they will secrete increased TSH. So this picture, increased TSH levels with decreased T4 and T3, they will say you that it is a hypothyroid state. Okay, and sometimes because of increased action of this TSH, the thyroid gland size will increase. So that is known as goitre, or it can form a MNG, multinodular goitre. So this is the thing. This feedback mechanisms we should remember in order to know the interpret the investigations. Okay. Okay. Now the functional unit of thyroid gland is a thyroid follicle. So what it contains? So it is a spherical structure. Okay. So in the silent stage, so it has one layer of cells here, lining single layer of polarized epithelial cells will be there. This cells, this one, these cells. Okay, and the central is the core. A proteinaceous fluid is there, that is known as colloid. Okay, so as it is given here, colloid. So when these functional unit of thyroid gland, this follicle is silent, these cells are actually cuboidal cells. When they're activated by the TSH, they become columnar cells. So that you should remember. Now, how does this TSH signal mechanism work in each of these cells, cuboidal cells, and it will activate this two columnar cells? So they will the TSH will attach to the TSH receptor, TSHR. Okay, and that will cause and this is the colloid inside. Okay, and that will cause increased cyclic AMP production and stimulate the thyroid hormone synthesis steps and induces follicular cell hyperplasia. What is hyperplasia? Increase in the number of cells is known as hyperplasia. What is hypertrophy? Increase in the size of the tissue is known as hypertrophy. So there is follicular hyperplasia and there is increased synthesis of T3 and T4. Okay, so that is of the physiology. Still physiology is there. Now how these thyroid hormones are synthesized, this is also very important to know. So what are the molecular steps of hormone synthesis and secretion? So I said the functional unit is, so this is a columnar cell. Okay, and this is the colloid region. Okay, and this is the bloodstream. This is the bloodstream. Okay, now what will happen? So there is a transporter known as sodium iodide symporter, NIS. So iodine from the bloodstream enters the cuboidal cells through this sodium iodide transporter. Okay, sodium iodide transporter. So this is known as step 1. This is known as iodide trapping. Okay, what is the clinical relevance? Normal function requires 100 to 150 microgram per day iodine. Sodium iodide symporter is a conduit for radioactive iodine ablation. So this is a clinical aspect of this. So when you give radioactive iodine, so it will enter through this sodium iodide symporter and it will damage the thyroid gland in patients with hyper MNG or hyperthyroidism. Okay, so first step is iodide trapping from the sodium iodide transporter. Second step is apical efflux, meaning the iodine which has entered now, it will go into the colloid now. So it is going into the colloid by a transporter known as pendrin transporter. Pendrin. This is important. Why? What is the clinical of this relevance? There is a syndrome known as Pendret syndrome where there is there is a malfunctioning of this pendrin transporter, because the iodine is not entering into the colloid, so the thyroid hormones are not synthesized. That will result in goitrous hypothyroidism, meaning the thyroid gland will get enlarged, along with there will be hypothyroidism, because there is no transporter, so thus iodine cannot enter into the colloid from the columnar cells. So along with that, there will be deafness, sensory neural deafness. So combination of sensory neural deafness along with goitrous hypothyroidism is nothing but Pendred syndrome. Okay, that's the clinical aspect. So similarly, so iodine is entering from here. So in the columnar cells, there is a protein known as thyroglobin, which is synthesized here. Okay, in the Golgi apparatus and endoplasmic reticulum. So that is also, that protein is secreted into this colloid. So thyroglobin is present in a very much high quantity in this colloid region. Okay, now the first step was iodide trapping. The second step was efflux of this iodine into the colloid through the Pendred channel. Now the third step is the oxidation. So this enzyme is very much important, thyroid peroxidase enzyme, because in the most common hypothyroidism, that is autoimmune thyroiditis or Hashimoto's thyroiditis, there is production of antibodies against this enzyme. So this enzyme is damaged, that's why there is no production of T3 or T4. So that's the clinical aspect of that. So oxidation will be there. So after the oxidation, so this iodide will be converted into reactive iodine. Okay, so the step 4 is now reactive iodine. Step 1 is organification. So this reactive iodine attached to the thyroglobulin now. This reactive iodine will attach to the thyroglobulin. So for example, this is the thyroglobulin protein and this is the reactive iodine which is getting attached to it. Okay, so that gets attached to thyroglobulin. Okay, when that gets attached, so if one molecule of iodine is attached to this thyroglobulin, that is known as MIT, that is monoiodotyrosine, or two molecules if they are attached, that is known as diiodotyrosine or DIT. So MIT or DIT. Now the fifth stage is coupling. What is coupling? When MIT combines, so MIT has one iodine and DIT has two iodine. So when MIT is combined with DIT, it forms T3, and when DIT is combined with DIT, it forms T4. Now these are the steps of the formation of these thyroid hormones. Okay, number one is iodide trapping. Second is apical iodide trapping through this sodium iodide transporter, symporter, then Pendred transporter, then thyroid peroxidation, then organification. Okay, organification, then coupling. Now after production of this T3 and T4, thyroid gland secretes T4 and T3 in the ratio of 14:1. T4:T3 is equal to 14:1, meaning T4 is more than T3. And remember, T3 is the active form, whereas T4 is not the active form. So in the peripheral tissues, T4 is converted into T3 and T3 will act into the target cells now. Okay. Now this, in this ratio 14:1 ratio, so these T3 and T4 are released into the circulation. How? So they are taken to the columnar cells through endocytosis. They will form a vesicle, and from there they will go into the circulation, T3 and T4. Here they will combine to some proteins, like the most important protein is thyroid binding globulin. Okay, second is transthyretin. So 80% is combined with this thyroid binding globulin, and some 5 to 10% is combined with transthyretin, and one more protein is there. So those proteins, and third is albumin, okay, third is albumin. So very much less quantity is combined to albumin. So these three proteins, this T3 and T4 will attach, and they will move into the body through the circulation and act on the target cells. So that's about the molecular steps of hormone synthesis. Now one important effect we should remember. What is that important effect? The Wolff-Chaikoff effect. What is Wolff-Chaikoff effect? So it is a physiological response to acute iodide load, when the iodide is very much high in the body. So that is a response to that. So what happens is, when there is acute massive iodide load, there is a transient inhibition of this enzyme, thyroid peroxidase enzyme, and organification. So that will lead to decreased production of T3 and T4. So what will happen? So in normal thyroid gland, where there is increased iodine load for some reason, when there is increased iodide load, so the normal thyroid gland, instead of producing more and more T3 and T4 because of increased iodine, it will not produce, because the gland will inhibit the thyroid peroxidase enzyme, and it will also so it will inhibit the TPO enzyme. So because of TPO enzyme inhibition, the normal gland will not respond to this increased iodide load, and normal secretion of T3 and T4 will take place, and there will be no resulting hyperthyroidism. So once the iodide load is lost, again the thyroid peroxidase enzyme is reactivated, and there will be resumption of normal hormone synthesis. But this is not the case in the abnormal state, that is when there is autoimmune antibodies around thyroid, for example in Hashimoto's thyroiditis patient. So this Wolff-Chaikoff effect is lost. So when this Wolff-Chaikoff effect is lost, patients fail to downregulate the sodium iodide sym-porter adequately. So that means in Wolff-Chaikoff effect, there are two things which are happening. There is inactivation of TPO enzyme, and there is downregulation of sodium iodide transporter. But in this autoimmune thyroiditis patient, this will fail to happen. That will lead to persistent profound hypothyroidism. Why that will lead to persistent profound hyperthyroidism? The sodium iodide sym-porter is not down-regulated, and the iodine is coming and coming and coming and coming. So the TPO is not reactivated actually here. In the abnormal state of this thyroid gland, the TPO is not reactivated because of persistent presence of this iodide. So that will lead to persistent profound hypothyroidism. So that is the drawback of affected thyroid gland in patients with thyroiditis. Okay, hope you have understand the physiology of this. Okay, so Wolff-Chaikoff effect is basically thyroid gland is protecting itself from high iodine load. Okay, the transport and peripheral metabolism. Okay, so I said already, so this is the plasma. So thyroid binding globulin is there. So protein bound fraction is more than 99.9% is T4, 99.7% is T3, and 80% of that is bound to TBG, thyroxine binding globulin, and T4, and remaining is bounded to the transthyretin and albumin, as I already discussed. Free unbound fraction is only less than 0.11% of T4 and 0.3% of T3. This is important to remember. The free fraction is very much less. So less than 0.1% of T4 and less than 0.3% of T3. Okay. And only free molecules can diffuse across to exert the biological effects. Only the free, not the bounded one. So when they cross to a cell in the target tissue, there the T4 is converted to the T3, which is a active hormone. And remember, the half-life of T4 is more, that is 7 days, compared to the half-life of T3, that is only 18 to 24 hours. 85% of circulating T3 is generated peripherally from T4 outer ring 5-deiodination. So this is enzyme 5-deiodinase enzyme which converts T4 to T3. Long half-life is T4, short half-life is T3. Active hormone is T3 and non-active hormone is T4. Okay. Now, just to know about the enzymes, there are three types of enzymes which convert T4 and T3. Three types of deiodinase enzyme. That is, number one is D1, D2 and D3. So D1, what it does is, it will generate bulk of circulating T3 by deiodination. That means it converts, normally it will convert T4 to T3 in the peripheral cells. That is D1. D2, it regulates the intracellular T3 concentrations. Okay. And in pituitary, it mediates negative feedback inhibiting through the TSH secretion. So mainly D1 and D2, what they do is they convert T4 to T3, and D2 has a role in negative feedback inhibition. D3 is actually related to pregnancy. It is present in placenta, and it limits maternal fetal T4 transfer. Okay, this what it does, D3, what it does is it inactivates T4 to reverse T3. Okay, reverse T3 and T3. Okay, it converts T4 to reverse T3, and reverse T3 is not a active form. So what is the ectopic massive upregulation? This is important. In severe non-thyroid illness, what that means? So the TSH is low, T3, T4 is low, and the patient is in sick state, but he is not hypothyroid. So that is known as sick euthyroid syndrome, or non-thyroidal illness. In that condition, this D3 is upregulated, and more number of T3, the active hormone, is converted to reverse T3. So that is one important thing. Okay, should be remember. And one important thing to remember is all these deiodinases are selenoproteins, meaning they require selenium. a micronutrient. So this is critical for metabolism. All three deiodinases are selenoproteins. They require selenium. When there is selenium deficiency, so that patient can also have that patient will have resistance, actually peripheral resistance. Why? T4 is not connected, T3, even though thyroid gland is secreting the hormones properly, but T4 is not connected, T3, because of this inactivation of this deiodinase enzyme. Now how does it act in the target cells? So basically, because it is very important, and each and every cell of our body requires thyroid hormone. It is a hormone. Okay, so T3 will get attached in the peripheral this MCT8 transporter. From there it will enter into the cell, in the cytoplasm, and from there it will go and act on the thyroid receptor inside the nucleus, thyroid receptor. So by acting on the DNA, it will produce something called as thyroid response element. So that is that will cause T3 binding to the thyroid receptor, causes co-repressor dissociation and co-activator recruitment, and then there will be initiation of gene transcription. Then there will be production of final proteins which are necessary for which are essential metabolic proteins. What is metabolic? What is metabolism? So the basic machinery of the cell is metabolism. So a industry which works in industries, you see many machineries which are running. So a cell is actually a micro machinery. So to run that machinery, some proteins are required. So those essential proteins, those metabolic proteins are produced by, so metabolism is affected by thyroid hormone. Okay, metabolism means, so if it is a fuel, it acts as a fuel actually. Thyroid hormone is a fuel for metabolism. If you give more thyroid hormone, the metabolism of the body will increase. It is like though if you give accelerator to a car will heat up. Okay, because the metabolism of the car, the functioning of the car is increased. And if you don't give fuel to the car will cool down. Okay, or it will not start only. Okay, that is decreasing the metabolism. So in the hyperthyroid state there is increased metabolism, in the hypothyroid state there is decreased metabolism. So in unliganded state, in hypothyroidism, active transcription is silenced. So that will cause, so metabolic proteins finally they are not produced. Okay, they are not produced. So that will affect each and every cell of the body, and the important organs also, like most importantly the brain and the heart, neuropsychiatric, cardiac, pulmonary, and liver, and the muscles, everything is affected. Okay, so that's why the thyroid hormone is important. Okay, hope we have understood the concept till now, physiology till now. Now in the next class we'll discuss about the abnormalities of the thyroid gland. Thank you for listening.